Okay. The time that we're in now is, as everyone knows, very interesting. The pandemic has changed a lot about the way we're working in the world. But the difference between this pandemic and the previous one in 2009 that I worked with was that we also have the addition of the possibility of digital health. I've worked in digital health since, I don't know, 2010, something like that, back when more the focus was on SMS than anything else. And I've seen it grow over the years to being something that is a tool that you might be able to use some places and it won't really work because nobody knows what they're doing, to something that in many environments is a given in terms of possibility, so that we do have options in what we're doing that are well beyond what other people might have been able to do 5 years ago. And so it's a great opportunity that we have, but it's not perfect. I participated with DataKind and Living Goods, and Save the Children and DataKind and Living Goods worked together on a summit in December of last year, Digital Health 2.0, and we found a few different areas that were specifically of need within the area of digital health. First of all, interoperability. Yes, we need to have systems that are interoperable with each other, but also when we're considering community health workers, we want it to be simple for them. So it's not just that they have 12 different systems that can all fold up into one, but it's that they have systems that they can easily work with together. And that's part of the problem with siloed technology solutions. You have something for TB, you have something else for child health, you have something else for maternal health. Add COVID on top of that, and it's just a nightmare for the people who have to be working in the field. The data is not always reliable, and people don't know how to fix the problem on that. A huge issue, and that's one of the reasons that I'm presenting this the way that I am, is that there's a big gap between the creators and the users. So we have these wonderful ideas about the way things can be done, and so we want to impose that system on wherever we're working. Whereas what we really need is to find out from the users what their problems are, how they can work, and do human-centered design, where you're designing with the user in mind. And so if you start with the problems instead of with solutions, it makes a huge difference. And of course, there's gaps in accessibility. Yes, it's not everywhere yet. And even where there is digital health everywhere, supposedly not everyone has access to it. So those are the big issues on the digital health side. And now we're gonna, if you can go on to the next slide, please. Okay. We now have to address the community health work in terms of COVID. So we have COVID that's been an issue now since December 31st for many of us. And in May, WHO launched their newest guidance, which is interim guidance, but it's pretty good on community-based healthcare. For the people that are currently working in community health programs and who are providing health services for children, for pregnant women, for whomever in the community, that are now dealing with COVID on top of everything else. If you've attended any of these sessions or anyone else's sessions, you know that the community focus is crucial, because the health systems are going to be overwhelmed. So if everyone just goes to the hospitals, they cannot be treated. There's not going to be enough services there. So anyone who can be treated at a local level should be, and people who have other kinds of illnesses, in some cases, can only be treated in the communities because hospitals are being closed. So, so it's crucial that we look at what the community health workers are doing, how to prioritize the correct pieces of what they're doing, so that they're working on the right things, how to ensure continuity of care for what they had been doing before to get their service, whatever the different services are. So there's a lot of different pieces in this. I recommend this guidance highly for anyone who hasn't seen it yet, to see how it is that you can be adjusting what the community health workers are doing in their communities. Can we go on to the next slide, please? Okay, so here we're going into quality of care. Quality of care has been an issue for a long time, pretty much since community case management started, for community case management. People have, the community health workers often have competing priorities. They're working on a lot of different things and don't have enough time for each of them. And sometimes it depends upon what the funders have, what the local NGOs are working with in terms of what they can be working on at a given time. I have seen community health workers who have 3 and 4 cell phones because everybody gives them a cell phone. They have competing priorities. There's issues within CCM specific behaviors. For example, counting respiratory rate is a complex system, and it needs to be done right to make sure that you catch the cases of pneumonia that you need to catch and don't misdiagnose that. It is always a problem. It always needs to be worked on and to be improved. Using the rapid diagnostic test, there's a lot of different steps in there, and that's often a problem for the community health workers working on CCM. Stock management, making sure that their supplies aren't exist and that they're not expired, that they have enough for the people who are coming in all the time. And now there's COVID-specific behaviors that can be problems. Like, for example, and this is just a short list. This isn't everything that's going on. Knowing what the current set of signs and symptoms are, it has evolved over the last few months in terms of what's considered a symptom of COVID. At first, it was just difficulty breathing, cough, and a fever. But now there's a whole slew of other kinds of symptoms. Those need to be considered. Loss of taste and smell. I mean, there's a lot of different things that you wouldn't normally consider in these issues that need to be considered in there as well. So if they are specifically working on COVID in their communities, they need to know those, and they need to know it up to date. They need to know how to recognize those signs and symptoms. They need to know who can be treated at home versus the ones that should be referred to a hospital for more intensive care. That's specifically for COVID. In general, with community health workers, there's always a problem with data quality, making sure that the right information is down. When it's mostly with registers, it's even more of a problem. Because adding things up from page to page is very difficult, or even just adding down a line is difficult, depending upon the way they're set up. Counseling, what do they need to counsel? How do they do the counseling? And referral gaps. How do you make sure that the people that need to go to the health facility actually go? And those are all pieces. So I want to ask y'all now to answer this first poll, which is in terms of the big categories on here, which of these concerns you the most? We're going to have 3 different polls here. One is this one that just came up, and then we're going to have 2 that talk about the subcategories of CCM and COVID. So if you could answer this first one, in terms of which of those 1, 2, 3, 4, 5, 6 categories concerns you the most. We'll give you a minute to do that. And unfortunately, you can only answer 1. David, how many are we up to?
We have 61% voted, and people are still voting.
Okay.
Yeah.
Thanks, everybody, for your participation. That's great.
Okay, so competing priorities was the big winner on this. How do they decide what they need to be doing versus others? Okay, great. So now we're going to move right on to the next poll, which is in terms of the CCM specific behaviors. Which of those do you consider the biggest issue? Counting respiratory rates, RDTs, and stock management. And there could be others. We just want to choose from these three right now. And I do recognize that stock management at some point might be an issue under COVID as well, but right now there are no drugs. So. Okay, stock management. Okay, that's an interesting one too, because hopefully eventually that will be an issue, and well, not an issue, but they will have an option for some kind of a drug for COVID. Unfortunately, not yet, other than fever reducers. Okay, and the third one, which of these COVID-specific behaviors concerns you the most? Knowing home treatment versus referral. Interesting, because that's probably a problem in a lot of areas, is not knowing what to do with the people who come in when they're sick. Okay, good. Okay, let's move on to the next slide, please. So traditionally, when we talk about quality of care, there's always a lot about supervision. You need to do supervision. And then you want to improve the quality of the supervision that is done. But I have found over the years that the supervision doesn't happen. If you don't have funding, and you don't have staff, and if you don't have time to do the supervision, it's not going to happen. And in terms of COVID, it's even worse. The health facilities are overwhelmed, and they're not going to have time to go out and check on what's going on. And if they do check on someone, it might only be the same person over and over. So there's a bunch of CHWs that are never supervised. So what we're going to look at here is ways to work on quality of care that don't entail supervision. Okay, so let's move on to the next slide, please. Okay, we're going to go through several of these categories, and if you would open up the file that's on here, it's in another what do you call it? Another tab, which is, it's a Google Doc, and we're going to be going through this Google Doc and filling in some information on it. So what we're looking at here is, first of all, that in terms of challenges, in terms of competing priorities, is that, first of all, too much to do. The staff, the community health workers are overwhelmed with too many things to do. And the second is that they don't have any clarity in what their priorities are. Somebody might tell them it should be all on COVID. Somebody else says, well, CCM, you got to keep testing for pneumonia. Or somebody else says, but bed nets, it's malaria time. So how do they decide what those are? And some possible answers on that are e-learning, where they get an update on what they're supposed to be doing, how to do what they're supposed to be doing now. E-updates that say this is what your priorities are. This is where you should be working at this moment. And WhatsApp groups to talk with each other about complaining about what they're doing and figuring out what their priorities should be. Those are some possibilities. If you have any programs that you are using now, any on e-learning, I want you to go to slide 2, and if you could pull up slide 2 on there, David, and write on there any apps that you are currently using that involve e-learning, and then go to slide 3 if you have anything that you're doing specifically on e-updates. And then on slide 11, if you have any other digital solutions that you think might work on this. And I'm happy to see people start to put information in on here. Okay, so anybody, if you can write it in on, let's see, I'm not seeing anything coming up yet. If people are having trouble pulling up the Google Docs, can you write that in the chat box as well? Too much paperwork is another challenge, yes. I'm thinking maybe we should, because what I'm seeing writing in is on the dashboard slide, which we haven't gotten to yet. I'm wondering if we should go through all of these possibilities and then give people a chance to fill in. Let's, why don't we do that? Keep writing on your stuff here if you'd like, if you want to write things on here. But let's go back to the presentation, and then we'll hit this again in a minute. Keep writing on this if you'd like. But go on to back to the presentation on slide barriers to quality, CCM specific issues. Okay, so we talked about some specific challenges and some potential solutions or algorithms. There's a lot of different algorithms that are being used that roll right into the reporting system. E-learning again helps with that. Developing videos for specific skills, specific devices that, for example, test the respiratory rate, taking photos of the stock or of what's going on, or videos, taking videos of what the community health worker is doing and sending them to the supervisor, digital stock reporting forms, and your basic old-time phone calls to find out how people are doing and asking them about different aspects of their job. Okay, again, if you have some solutions for any of those, let's put them, keep putting those in the boxes. There's slide 2 is for e-learning, slide 4 is for algorithms, slide 5 is for videos, slide 6 is for devices, slide 7 is for photos, and slide 11 is for any other digital solutions. Okay, can we move on to the next slide in terms of challenges and potential solutions for COVID? Okay, we talked about the challenges and some solutions. You can have updates on the home screen on different new information as it comes out without overwhelming the amount of information that comes in. If community health workers got as many emails every day as I do, they would not be reading anything at all. It's insane. And I'm sure all of us are in the same boat on this. Again, algorithms for what to do when they're doing both CCM and they're working on diagnosing and assessing and treating COVID. Again, e-learning, again, videos, photos of for the stock as well, phone calls. And then when we're working with, and there's a lot of cases that private providers are being used a lot for COVID as well, doing a Yelp type system of referrals for private providers so that people know to whom they should be going, the ones that are of quality and the ones who are free. Can we go on to the next slide, please? Okay, poor quality of data. The data is often entered multiple times, is especially a problem with when it's on paper, which it still is for most community health workers. And the data is not used locally, so they're not as invested in having the information correct. So if the wrong numbers go up the chain, then it doesn't really matter for them because it doesn't mean anything to them. And some solutions, again, are the algorithms that feed directly into reports and real-time data that they can review as they go, and then dashboards that are available not just at the higher levels, but also to CHWs. Okay, and on this one, slide 4 again for algorithms, slide 10 for dashboards, and slide 11 for other digital solutions. Let's move on to the next slide. Okay. And this is for counseling. Counseling for COVID is a bit challenging because information is changing over time. What was correct a month ago might not be correct anymore. There's differing responses in different places. For example, the US CDC and the European CDC use 6 feet as a distance for social distancing. WHO uses a meter. What do you use in the communities that we work in? How to make it understood to the people who are listening to it. They're not going to understand a little picture of a virus, but what is it that's going to make a difference on there? Some potential solutions or videos or quasi flip charts on the phones or the tablet. Again, e-learning and SMS in some cases. So look at your e-learning slide, your videos, other digital solutions. And the last one is when to refer, knowing when they need to refer and how to follow up with the families, especially given the issues with social distancing and keeping the CHWs and the families safe. This one I have fewer ideas on, so anything that that you all have on that would be great. One potential solution is WhatsApp. Oh, this slide didn't change on this, sorry. Okay, so we're almost through with my time on this. So let's see, did we get any more information on the reports? Okay, so we're gonna talk through this in just a second. Can you move the slide down to there's.
You want me to show the Google Doc?
Slide it down to the resources one, just because the time is running short. One more, I think. One more, sorry. Okay, so let's open it up for discussion, and if you could put on the Google Docs to see what we have on there. Okay, so we have on slide 1 on the Google Docs. Go up to slide 1, see what we have. Do you see any other challenges? No one is paying attention. There are no real perceived repercussions from lax social distancing measures. Absolutely, and too much paperwork. Let's see, did we get anything on the chat, Steve, that you want to bring up?
Let's see, the one that came up here, where to find e-learning resources on COVID-19?
That is, I'm looking for that slide.
And as you're doing that, I'm just typing in two resources, additional resources into the chat box for solutions, the WHO Digital Health Atlas, as well as the WHO Digital and Innovations for Health Community Fighting COVID-19 is a great place to look for resources as well as to list resources.
That's great, great. So we have those in there. Okay, again, it's good to know what's out there so that we're not reinventing the wheel. The WHO course is I've gone through that. That's pretty useful. It's actually the, I thought it was called WHO Academy or something like whoa. It's available on the phone. Okay. Did anybody put anything in the chat box to look at? E-learning tools.
Right. We had one from Liz McNeil.
Okay.
Developed a virtual learning platform for nurses that we work with to carry on with training. It's a partnership with M. Schule.
Okay.
And COVID-19 digitalclassroom.org. And Vialmo, the 321 information line where people can call in and listen to information.
Okay. I'm going to try putting some of these into the box itself. Did anyone want to speak about any of these issues in terms of what people can be doing? I know that there's a lot more that people are already doing out there, and I would love to hear more about what's going on. Okay.
Yeah, thanks, Julie. Jeanne, this is Julie. We're getting some great ideas for resources. For those of you that have resources, could you just put the links in the chat box for us all? Because this will be recorded and put on the core group website, so we'll have direct access to these links. So I think, Liz, if you, McNeil, if you could maybe put your link in the chat box and anybody else, that would be great. Thank you.
And I think Jody also had some links that you could share in the chat box because she was having trouble getting him into the sticky notes. But I know Jody will be a great resource.
I'll put the ones that were put below in the chat box, below the e-learning one in the chat box, in case that's not in there yet. Okay. Did anyone want to say anything or leave it in the chats? Okay, just if we can go back to the last slide that I had on there, please. Just the resources. I just want to refer to a couple of resources. Okay, so UNICEF is putting together a catalog of apps related to COVID. And so if you go to the link that's on here, you can put your app into their catalog. I would recommend that because that'll get some good publicity for what you're doing. And then the guidance that I mentioned before in terms of the WHO community-based healthcare, the link for that is on here as well. And if you could, Steve, if you could put the link for the forum again.
Yep, I'll do that. Thank you.
Okay. Because there might be some people on now that were not before.
Jeanne, this is Julie. Do you have any, just a quick question for you here. In terms of the apps that you can put on the UNICEF catalog, do you have any examples of that, or have you seen any really interesting and helpful apps?
They have not, I had not seen any actually started yet. They just put out the call for, what do they call it? Call for proposals for, I forget what they called it, but they just put that out recently. I don't know if Karin Calendar's on the phone or not on here, but she might have more information on that.
And just as a related note, the innovate.who.int website, in addition to, of course, it's good to know what's out there, but there's also some moderation and vetting of the solutions that are here. So that's another way to get to have work from things that have been vetted and reviewed to some extent. So do take a look there, or if you have questions, do post them to the forum. Should be another good resource.
I'm just putting that on there again so that people see it. Okay, thank you.
Great. All right, we do have a couple minutes. If there were any particular questions on Jeanne's session, that was really informative to get that great overview of a lot of those potential options. Any questions that we'd like to have Jeanne address, or topics we'd like to discuss now? Otherwise, we can move on to Darlene, and we can have a time for a nice rich discussion at the end. And Julie, yes, that link that Jeanne just pasted, innovate.who.int. Okay, yes, is the link that we mentioned. All right, closing 3, 2, 1. Nothing else in the chat. All right, let's move to Darlene. Okay, oh, sorry, one last opportunity, one last note here from Diness. Medic Mobile shared the open source toolkit that fits this category of resource. Check out their website. So this would be the community health toolkit with their general modules, but also with their COVID-19 specific tools. Thank you, Diness. All right, Darlene, let's put it over to you. Let's tell us about the mitigation strategies for service disruption.
Yeah, wow. So thanks everyone for having me. I'm new to the Child Health Task Force, and Steve was the prior co-chair, and so it is with fear and trepidation that I attempt to somehow step into his shoes, and but we'll enjoy to continue to collaborate with him on the Global Digital Health Network. Next slide. So a little bit about Jhpiego. As you know, Jhpiego is an international NGO affiliated with Johns Hopkins University. A lot of our work since 1973 has focused on maternal child health, HIV/AIDS, and healthcare worker development status and training. I started my career in healthcare initially as a healthcare finance director in academic institutions of medicine, Georgetown University, George Washington University. And then in 2005, I bit the international development bug and started to work in digital health, which was called mHealth back in 2005. And so I spent probably the first 5 years of my career in the field directly implementing patient management information systems across Asia, Sub-Saharan Africa, and Latin America. And I would say that my primary interest is data systems and integration and interoperability of data systems. Next slide. Next slide. So I think Steve's going to talk a little bit about the objectives of my presentation. So what I want to do is talk about, from the digital perspective, what tools can organizations use to look at service disruption data, some of the bottlenecks and challenges with service disruption data collection during COVID, and then some consideration about how partners are mitigating the effects of service disruption using digital health. Next slide. Is there a poll that's coming up here now? Oh, okay, here. So in terms of looking at tools, I have a little backstory about why I think this topic is important. And it's a quickly moving topic, as different organizations and leaders in the field have disseminated many types of tools and platforms to collect service disruption data. So back early on in the pandemic, my organization asked my team to start to collect service disruption or service interruption data. And we really struggled with this because, as you know, in most countries, there's no one comprehensive tool that you can turn to really collect this data. And so as part of this exercise, and as part of my review, I think that when I start to look at service disruption data, there are 4 or 3 major categories: the modeling tools, mostly by the LiveSave tool, the global health COVID-19 country monitoring tool, and then looking at national health information systems or routine health information systems. So at this point, I think we're going to have a quick poll. Yes. So, I think it's really important as we continue this discussion about service disruption that we talk about some of the tools that you have experience with. And so the first question is, which of these tools do you have experience with in collecting service disruption data? National registries, national HMS, EMRs, DHIS2, facility assessments, CRVS, DH, population surveys, qualitative context. So we're going to take a minute to take the poll.
David, how's it looking? We got 88 participants. How many votes do we have?
We have 39 votes so far. People are
Okay.
still voting, so we can just wait for maybe 45 seconds more.
Okay. Okay, great. So looks like the winner is DHIS2. And then secondly, population surveys. And then a third would be, actually quantitative context surveys. I can't really see that, the percentage. Is that 55%?
Yes,
Steve?
55.
Yeah, so I guess that would be
Yeah.
number 1. Okay, yeah, interesting. One of the things that I'm going to discuss at a very high level is that with some of the context surveys, one of the real advantages is the ability to rapidly get information. Okay. So next slide. We're going to do a high level sort of review of these tools. And the first tool that I think, we want to talk very quickly about is the LIST framework. And what's interesting about the LIST framework is that some of the modeling is, very detailed and really shows some alarming projections about the impact of service interruptions or disruptions on child health. And they developed 3 different scenarios, and each scenario depicts the increased mortality as a result of service disruptions. And I think this data is very fascinating. It's been widely disseminated and provides a lot of, very significant information that could be used in informing ministries and then adjusting or making course corrections or supporting the response to the pandemic. Next slide. And this is just, actually from the LIST website, how the questions to service disruption were presented and analyzed. So there were certain hypothetical outbreak and response scenarios that would have an indirect impact on maternal and child mortality. There were 3 scenarios of various severity. The time frames were over 3, 6, and 12 months. And they used the LiveSafe tool list. And there was engagement in the first phase of modeling from a number of different organizations. Next slide. So I won't read all components of this slide, but this really sort of summarizes what the model impact of service interruption was for child mortality, looking at the different scenarios. And you can see that each scenario presents a more alarming picture of the impact on child health for both mortality and probably morbidity. Next slide. The next tool we want to look at is, which I think is very interesting, though I haven't seen a follow-up to this initial COVID-19 country monitoring tool developed by Global Fund since May. And the purpose of the tool was to detect early disruptions of global funded supported programs. It's clear, and they really highlight that it's not a rigorous monitoring system, but it does give organizations and donors an ability to have a quick look at the information specifically as it relates to service disruptions, and that they can take a quick survey and then respond. So the initial survey was launched in April 2020, and they released the first batch of survey results back in early May for 106 countries. And so what I'm going to show on the screen is just a graphical depiction of the survey results and how I do think this is an interesting tool, and I've tried to access it. I will list it at the end of this presentation as a possible tool that could be used to look at service disruption data for COVID-19. Next slide. So these are some of the objectives that were outlined for the Global Fund COVID-19 country monitoring tool. And basically the objective of the tool was to serve as an early warning systems for Global Fund countries and programs, to compare trends, and then to reduce this need for ad hoc requests, which we know as data folk or data system digital health practitioners, that there's always, during pandemics or emergencies, a significant amount of data requests coming from different sources where reliability and quality is always a challenge. And then what's really, really great, I found it that they did have a caveat that this is not a rigorous tool, that it really outlines potential risk and disruptions. Next slide. And so this is an example of the level of disruption to certain disease areas using the country monitoring tool. And I think this was early on in the pandemic. And so, I was wondering what it would look like if we, probably did the same analysis, more recently. Okay, next slide. And then here is an example. I just, did a sort of copy paste of the actual draft survey questions, which are pretty simplistic, but a good way to model how some of these questions can be used to collect service disruption and interruption information across our programs and projects. And so this will be available as the recording is made available on our website. Next slide. So I think when we looked at the polling that routine health information systems and contextual surveys figured high in terms of what people are using to look at service disruption data. And so I really want to talk about that a little bit, about the opportunities to use national HMS and EMR and national registries. For example, in our organization, we use our DHIS2 to collect service disruption and interruption data. And so one of the opportunities of using routine health information systems, for example, like DHIS2 or EMRs or other registries, is that health facilities usually have access to this information and can really run data quickly through queries. It doesn't require an in-person interaction. It can be done remotely or virtually, which is really important in this environment. And that based on your data platform, you do have the possibility of gathering a lot of information across, disease areas in a quick time frame. In terms of capacity gaps, usually there's a cadre of staff that already have experience using these routine health information systems. And in this environment, there's no need for training or development or creation of a new solution. And then usually these platforms, for example, like DHIS2, the basic visualization functionality makes analytics easier. Or, files could be downloaded into Excel or Tableau or Power BI for more sophisticated data visualization and analysis. Okay, next slide. And this is an example of data collected using the national DHIS2, looking at trends. And what this country decided to do is to look pre-COVID and then right at the peak of the epidemic and looking at some of the trends. And so this information is accessible and can be created from and collected from DHIS2. It can be visualized for, I think, some really good information. Next slide. So what are some of the challenges with using digital tools and platforms? Mostly challenges around collection and data quality. Do I have a poll here, Steve, or should I keep going?
Keep going on this one.
Okay, sure. So I think one of the challenges is exactly where and who is the pandemic will impact most. The types of people affected, where they will be receiving their services, what services do they receive. Sometimes with surveys or even from DHIS2, it's hard to really, really dig a deeper dive into some of their data. And then, secondly, one of the challenges is the rapidly changing pandemic. And without targeted data collection, a lot of time decision makers are left with a lot of unknowns as to where do I support or target services? Where do I strengthen performance of healthcare workers? How do I continue to focus on equity and access? So though this data is available, sometimes, some of the questions just looking at the data, are not sufficient. So there are challenges that are inherent in managing a pandemic. Next slide. So we always talk about the supply side and the demand side and digital tools and the challenges in capturing indirect service disruption. On the demand side, can service disruption be impacted by stigma, fear, misinformation, lockdowns? And then on the supply side, commodities, stock out, health workforce pause or diverted services. So all of those also impact service disruption and interruption. Next slide. So when we talk about digital tools and platforms and supporting the mitigating effects of digital health, I think what's really important is that we did learn a lot of lessons from the Ebola outbreak. And I really applaud USAID for actually disseminating a tool for the digital health response in relation to COVID-19. And at the basis and at the core of that document is the lessons that we've learned from Ebola. That when we look at trends and analysis for routine health information systems, that we think ahead and we address the challenges with routine health information systems, and that we start to consider other tools. But I think one of the most important things from the Ebola outbreak was that during the midst of a pandemic is not the time to create a new tool or to spend a lot of time bringing on board a new tool or a new system. In terms of some of the reasons I highlighted before is that you do want an existing tool that people already have familiarity with. Next slide. So again, just want to highlight the case for digital health in terms of, the COVID pandemic. Again, the Ebola outbreak really created what was called a fog of information that really made the response difficult. And, I want to highlight the importance of information to the response, that there should be a concerted effort to focus on data and digital systems, and then try to utilize existing health information systems that are already in existence. Next slide. Am I coming on a poll now, Steve, or did we miss one? Oh, there were two.
I think we would gone past that one, so we'll just keep going.
Oh, okay. So in terms of routine health information systems, I think looking at trends and analysis can help planners and managers identify some key components, the occurrence of the disease, whether it's changing over time, where the particular disease occur, and where programs or interventions are most or less effective, and then the types of health conditions receiving the services using the national HMIS, EMRs, registries, DHSI2, or facility assessments. Next. I think a poll's coming up now. No? In using routine health information systems, there are some key components that it's important to have the updated master facility list, that routine health information systems analysis state clearly which providers are included, that information on the completeness of reporting from routine health information systems is essential for interpretation data, because a lot of times, for example, DHIS2 information is aggregated or reported quarterly. So an analysis of looking at the data on a monthly basis may not give you an accurate picture. And then also facility data is very important, but it only focuses on people that visit or use the facilities. And so there may be significant gap, for example, in faith-based or private institutions that don't report directly into any Ministry of Health system. Next.
Okay, so we told David, we did want to ask people to participate and chime in with challenges they've seen in using routine health information systems. You can go ahead and vote as Darlene talks through this.
Okay. Are we going to put the poll up, or?
This is an open question, right? I think that
Yes.
people can just type on the chat box because we
Okay.
only can have multiple
Right.
choice options on Zoom. Yeah.
So what we want to talk about right now are any challenges that you've experienced using routine health information systems for service disruption, data collection, or analysis. And I'm going to talk really quickly about what some of those challenges are. One is data reliability and completeness. For example, that information isn't always up to date and may only reflect aggregate data, as I said earlier. There's always a challenge with indicators, denominators and numerators. There's gaps in data. For example, only the Ministry of Health facilities may be part of the system, and all of the health services in a country may not be adequately reported. And that also includes the private sector reporting, which often isn't included in some of the national Ministry of Health facility reporting. So the question in the chat box is, what are some of the challenges that you've encountered in using routine health information system, particularly as it relates to COVID-19, and then more specifically around service interruption and disruption? So we're going to give everyone a couple minutes to.
Right, and it looks like it was typed in from Lavanya. Hello, Lavanya. Indicators, as you, yeah, denominators. And others, please type them in.
And I think I'm about out of time. I have 2 minutes, so I'm going to close very shortly, Steve.
You're doing great. Okay, I'm not seeing anything else come in the chat, but if they come to you, please, denominators, okay.
Denominators, absolutely, yeah.
Yep, data completeness and facility versus community data.
Yes, absolutely.
Denominators, lots of it.
Yeah, denominators, yeah. Okay.
Great, all right, why don't you keep moving, Darlene, but you're right on track for time, so take your time.
Okay, next slide. So real quickly with population surveys, I think, you know, I've learned recently that with demographic health surveys that they can link with GIS. And so that gives a rich set of data on health facility locations, infrastructure, roads and rivers. And then there are tools that can be used to do a deeper analysis with DHA surveys. Next, trying to give time. Challenges, denominators. Sometimes it takes some level of expertise to be able to do analysis from DHS surveys. Also, it's based on the last census information that may not be accurate or up to date. Some question the methodology used to collect census data, and then the coverage rates. You know, sometimes the denominators and numerators can give you data that's, you know, that's over 100%. Next slide. Almost done. And I think when we did the poll that, you know, there was a lot of interest on basic, qualitative, and context surveys. And I really like this methodology in addition to using routine health information systems. One is because you can really get a quick, you know, you can get data collection occurs very rapidly, and you can, you know, really get some information in a fairly short time. You can do some quick high-level analysis very quickly. You can, the information is generally reliable, repeatable. You can do it over again. Based on stigma, it can be anonymous. So you have the flexibility of asking questions without, you know, folk identifying themselves personally, but, you know, you may want, would want to have the information about the facility or the country, and that it can be performed remotely, which is great. You can just send out a survey over email. But one of the challenges is that sometimes it's not rigorous. It's difficult to really understand some of the intricacies of the data, and then the data validity may be also a challenge. Next. I'm rushing through, Steve. And I just wanted to shout out for my M&E team. I do want to talk about the importance of indicators, and I think someone talked about denominators and numerators. I think that is really important. And so these are some guidelines about, you know, how indicators are really important, and that I think what's really important is that the data needs to be available, and data collection needs to be simple. And, you know, the coverage of essential services should be drawn from existing indicators. So it's not really, you know, if you could use existing indicators, I think it's preferable as opposed to creating new indicators, even though sometimes they can't be avoided. But it has to be really focused and prioritized on the country context. And this is my last slide. Next slide. And I want to thank you because I think I'm right out of time. And this was just a sort of start of a conversation about what's out there in our attempt to respond to the COVID-19 pandemic, and what some of the tools we could use to collect data and to better inform, support, and mobilize our resources. So thank you very much.
Great.
Thanks, Steve.
Sure, thank you, Darlene. And did just want to say thank you to both of our presenters here. You covered quite a range of information, and most importantly for me as a moderator, I didn't even have to keep either of you to time. You both finished exactly on schedule, which is probably a first. So thanks again. We do have some time for Q&A here. It looks like we've got about 12 or 13 minutes here before the half hour. So do type your questions in. Let's see, it looks like we do have a couple of questions that have come in. So from Jhpiego, can we rely on the routine health information systems for low and middle income countries, HMIS? So Darlene, maybe you or Jeanne, if you'd like to take that one.
Darlene, I'm going to punt that to you.
Oh yeah, you know, that's a really great question, and I think all of us in the field sort of grapple with the reliability of what's in the HMIS, and as they used to say in the old days, junk in, junk out. I think that when an HMIS is the sole source of truth, where countries have made an effort to use that one system or the national HMIS as the single source of truth, and there's commitment to having people use that particular system for the collection and analysis of data, then yes, I think it's reliable. But what we do have in a lot of our countries is that we have parallel systems that are disease siloed. And so, you know, I guess the answer is yes and no. I think it's a mixed bag, and a lot of it depends on the country context. And Steve and Jeanne, I don't know if you wanted to add to that.
I agree. And again, like I said, but I might not have said it very clearly. The biggest problem for me is that when the community health workers don't actually use the data themselves. Mm-hmm. So the information, the junk in, junk out, true, but why is it junk? It's because it doesn't mean anything to them. It's something that they just have to send on. So if systems can be set up where they're using it themselves, it will matter more. First of all, you want to make sure that it's easy for them to put the right information in. Obviously, you want to make it as automatic as possible, but you also want them to be able to see whether the information makes sense or not, because they are using it.
Yeah. Yeah, I mean, I agree, Jeanne. I think that's a really great point about the data use component is really critical to data reliability and data quality. It's an excellent point.
Sure, great. And again, please type any questions in here. We do have another one from Jhpiego. So in a low resource setting, what 2 to 3 methods to assess the disruption should work in your experience and opinion?
Sorry, what's the question?
The question is, what would be 1, 2, or 3 methods to assess the disruption? So I think you've covered lots of different ways that you could, a full range of indicators. What would you recommend as far as, particularly in a low resource setting?
Yeah, if I wanted a quick, if I wanted some real quick data, I would do a qualitative or a quantitative survey. And I think that's quick. It doesn't require a lot of resources to get that information. I think the second requirement would be to, the second thing I would recommend is if you have a national HMIS would be a good source like DHIS2 or an EMR or registries. And then 3, some of these complex models really provide some striking information. If you really want a quick turnaround, then looking at one of these models may not be the easiest thing to do in the midst of a pandemic. I don't know if Steve and Jeanne wanted to add to that as well.
Go ahead, Jeanne. I've got a question queued up for you too. So go ahead.
No, I just I'm just very concerned about all the service disruption that's already happening in countries that haven't even had very many cases yet, and how much that's putting more focus on what's going on in the communities in terms of their being given more of a brunt. That's just where I'm most concerned, but I don't have an answer. I just have a question.
Yeah, but that's a great question. Again, I would say the surveys are always a way to get some quick information about, what's going on. But there are limitations to qualitative surveys, but at the very least, it would give you some preliminary information to look at the gaps. Yeah.
Right. And so you guys both covered quite a range here. Jeanne, you covered a huge range of solutions that could be used, and Darlene, you covered, focusing on the data side, many different ways that data could be collected. So, for those of you who might be feeling a little overwhelmed by the amazing proliferation of solutions, and I'm thinking also back to a resource that UNICEF had put together at one point, collecting some potential solutions. As well as one put out through ICT Works, and we were well into the hundreds of solutions. So the easy question, knowing that digital health tools can be used to an effective COVID response, how would you help figure out which ones to use? You've decided we're believers now that these things can be used, but we can't do everything at once. Where would one start? I'll kick that over to both of you.
Jeanne, do you want to start with that, or do you want me?
Okay, punted to you before, no problem. I would start with figuring out what people are already using in the country. I would start at the country level because I don't think that it's a one-size-fits-all. Just because this thing is fabulous in Botswana doesn't mean it's going to work in Nepal. So I would start with figuring out what is going on in the country, and that could be just a ask around to figure out what people are doing, not something we have to do a survey of any sort, or it could be a qualitative survey that's pretty brief to figure out what people are already using, what kind of systems can roll up, and where it is that the Ministry of Health wants the community health workers, specifically is what I care about on this, to be working, so that whatever is done is added onto it. If they already have something that they're using, some kind of a resource, see if that resource can be expanded to what's needed rather than starting over from scratch. Since it seems like a lot of the focus has been on the e-learning side, I would start with the WHO e-learning module and see if that's something that can be used in the country. But then I don't have a preference on the other e-learnings. There's a lot of really fabulous ones out there. I can punt that one to Steve in terms of that. But in terms of what is actually being used in the country, I would say find out what they already have before we start chunking another piece on top of it.
Yeah, I agree with you, Jeanne. Two other sources of information. One is that I think, you know, USAID has released some guidance on what I call ordained data collections tools for COVID. And I don't want to name those two as an endorsement, but they are listed. And so I would consider that that listing from the USAID website. There are so many solutions that are out there that one does have to be careful. But again, the country context is important. Using an existing system is important. If you have DHIS2, and this is not focusing on e-learning, but if you have DHIS2, if you're using ComCare for mobile data collection, you know, if you have a national EMR, those are existing sources that I think should be considered initially. But I'm going to punt it over to you, Steve. I know the Global Digital Network has done a lot on this. I've had a lot of discussions on this as well.
One more thing, Darlene. You made me think about another piece that I'd not mentioned. I can't believe I haven't. If there's nothing going on, or if you haven't had any experience on this, look first at the principles for data development.
Yeah.
In terms of what you need to be considering. And we mentioned a lot of those things indirectly in what we've been saying. One of them is design with the user in mind, which is why you would find out what's already going on in the country and what community health workers are actually capable of doing, and if they have 7 phones and whatever it might be. Open source tools wherever possible, although we know that's not always feasible. And there's 9 principles?
Yeah. And thanks, actually, Jeanne. That's a great segue. Lavanya had another question. So I did type in the URL for the Principles for Digital Development. So that's a digital principles.
Before I said that or after it?
You read your mind.
Am I cheating by looking at it?
But Lavanya had a question about if there are guidelines or recommendations to help data more meaningful to stakeholders or organizations. I'll kick out 2, and then it would be great to hear from Darlene and Jeanne as well. But Principles for Digital Development, to the website, there's a whole suite of tools and resources and examples there that are around this exact issue. You know, being data-centered, designing with the user, and these are all ways to make sure that the data can be more meaningful. No Measure Evaluation has put out quite a number of resources around data use and data quality, so that would be another place to look. But Darlene and Jeanne, others, I'm sure you have others as well.
No, those, I would agree with those as the primary sources that you know, that I would use to reference those subject areas. I don't have anything to add. I think those are great sources.
Yeah, and I think we've given a lot, so I think we're okay with that.
Yeah.
Okay. Well, it looks like we are at 11:29. We're having a few people filter off. I don't see any questions in the chat. Julie, this is probably a good time to turn it over to you.
Yeah, wow, perfect timing, great. You know, I certainly, I just wanted to say what a pleasure it was to work so closely with the Child Health Task Force, specifically this great moderator, and Steve and Darlene and Jeanne, the Digital Health and Innovations Subgroup. You know, we have been doing this for 13 weeks, and we've always been really trying to gather and garner resources, and today was the most active in terms of sharing. This call will be recorded, and within 24 hours, it will be up on our website. On the resources page for COVID-19. I thank you, Steve, for being such a great moderator. The insights, Jeanne, that you started us out with, and being able to participate and bring our ideas to the fore, and Darlene really looking at how to mitigate some of these issues and understanding that there's so much out there. But this call of all the calls we've done has really been able to do a deeper dive into what it really means in terms of our global response. I thank you all for, on behalf of the team at Core Group, for being with us. And I encourage you all to re-look at the slide decks and the resource list, which is very easily on the chat box that will be in our recorded section of our website. So thank you all very much, and I wish you and your families a wonderful day. And with that, I will now formally close this amazing call. Thank you.
Thank you, everyone. Have a good day.
Thank you, David. And thank you for joining, Diness. It was wonderful to have your comments in the chat box and so great to work with you.
Well, thank you for facilitating, Julie. This was really excellent, and I think an excellent webinar. Thanks, David, too. Presenters were great, and just a wonderful experience of collaborating.
Really deep dive, and you know, it's time for us now to be grappling with those issues in a very productive way, and I think that's what I take away from this call today. Much gratitude that we've been able to actually get to that level rather than just sharing the kind of the large overarching issues.
Yeah, no, wonderful, and nice weekend.
Yes, have a great weekend. And it's, again, so lovely to work with you, Diness. Take care, and thank you so much on behalf of myself and all of the team.
And same, Julie. Bye-bye.
Great.
I just want to echo the thanks. I sent a little chat, Julie, but this is Elizabeth. Thank you again for the collaboration.
Yes, thank you so much. And it's been wonderful to work with you. Like I said, you guys are fantastic. And what an interesting group. Again, all the different subgroups bring such a different element for the Child Health Task Force. I'm really pleased that we were able to work so closely with you.
We are too. Hopefully we can do it again.
Absolutely. Yeah, have a great weekend. And I'll follow up with a bunch of links as soon as.
That would be great.
Okay.
Yeah, everyone was sharing a lot. Thanks so much. Have a good weekend too.
You too. All the best.
Thanks, Elizabeth, too. Thank you.
Yeah, thanks, Diness. Bye.
Bye.
Bye.